Thanks so much, Jane. This is going to be a pretty quick case. So Dr. Richard has done a nice job of introducing the SPECTRA study, which is an incredible piece of work with, like he said, a lot of different potential explanations for the mechanism of action, what it's doing to affect the natural history of disease, and potentially addressing questions like HAPS about what's happening with cardiac output. And I think the short answer is that there are a lot of things happening, including hemoglobin, including changes in myocardial mass in both ventricles. And I think we need to do more. But this is about a patient who came under my care. Some of you know I'm a basic scientist. I spend most of my time in the lab, but we were trying to get our sotatercept preclinical study published at the time that this patient came under my care. He had been treated for pulmonary hypertension, but actually had scleroderma with some substantial interstitial lung disease. He found his way into the SPECTRA study, but not before having a very bumpy road that year before, where he was repeatedly hospitalized with courses of IV diuretics. Sometimes they were done by this nice home hospital modality where he didn't even have to get admitted, but he really needed to get bailed out with IV diuretics. And he was on pretty maximal medical therapy. And he had, in the context of coming into my care, had gained 20 pounds from a recent discharge. But what was different about this last discharge is that he had gotten put on the SPECTRA trial just a few months prior. And I'll tell you a little bit more about his interstitial lung disease. His lung indices were in the mid-70s, so just okay enough to be able to get into the SPECTRA trial. His PVR was, I'm going to show you in a second, but I think it was like 5 or 6. Also qualified there, and a 6-minute walk distance was kind of middling as well. But when we admitted him, unlike his previous hospital courses, we were not able to diurese him with the usual combination of augmentation and IV diuretics. Actually, he started spiraling down pretty quickly and looked like he was almost cardiorenal. And we did what I thought was going to be a reasonable way to assess what was happening in SPECTRA. We did an echocardiogram, which showed actually identical degrees of RV dilatation and RV dysfunction, and even to the single digit, an identical RVSP to what he had been prior to starting on sotatercept. So I was a little disappointed, because I was trying to publish my paper and hoping that this trial would work out, and asking myself all kinds of questions about what might have been happening here. There was also some interesting lab findings. So you know that sotatercept was developed as an anemia drug, and within 3 or 4 weeks, you should reliably see a 2-point hemoglobin increase on the high dose, and he was on the high dose of 0.7 milligrams per kilo. And we did not see that hemoglobin increase. In fact, his hemoglobin and his blood indices were all worse than before he started sotatercept. So this is a little puzzling too. He was known to be iron deficient, but he was on repletion, and this didn't really get addressed by the sotatercept. We know that this is a limitation to how high we can go with sotatercept, that this increase in red cell counts poses an issue for those of our patients who are on the high end of the spectrum for their red cell counts or their hemoglobin. But on the other hand, we'll take it as a favorable side effect for the patients who are anemic or close to being anemic. We know this helps in our heart failure patients as well. They also get a little thrombocytopenic. We used to think that this was due to a reciprocal effect on the common erythroid macrophage progenitor cells. But I'm not sure that that's entirely accurate, because there are drugs in this family that can increase red cell counts without causing thrombocytopenia. So anyhow, this is the background that we went into this. And so the question we were faced with was, why did this patient not have a clinical response to sotatercept? And there could have been, you know, there could have been any number of reasons, but assuming that this drug would work in the appropriate patient, we questioned whether he might not be the right kind of patient for the study if he was more of a group 3 patient than a group 1 patient. We know that systemic therapies generally don't go well in group 3 disease. And this was being positioned as a group 1 treatment for pulmonary hypertension. We wondered if he had just sort of reached the end of his road and there was not much that we could salvage. We didn't really think at the time about the potential for reverse remodeling or modifying his natural history. We're just looking for any kind of response. Or could there be something else? So I'll stop there and see what thoughts you might have.
So the dose of Remodulin is pretty low, okay? Even in this day and age, I mean, you're pretty much talking about driving people way up to hundreds of nanograms. So that's one possibility. Most patients who do respond seemingly to our pH meds have one pathway that predominates everything else. And when you hit the right pathway, they get dramatically better. Now, it is conceivable, it's likely that there are other pathways that are going on that we don't hit yet at all. And this guy may have one of them, okay? The other possibility is because of his cardiorenal state, you can't diurese him because you need to change his diuretics, okay? And work on his Renin-Aldo system, basically. So I might start there and see what happens.
Those are great thoughts. Yeah, not on, quote, maximal medical therapy with triple therapy, but maybe not maximized. Maybe this combination and the fourth drug weren't the right drug for him.
And then the obvious thing, the other potential is that although sotatercept works to balance TGF-beta, in this guy, it's not that important for his disease.
Okay, good thoughts, good thoughts. So we did escalate his diuretics. We threw pretty much everything that we have in our formulary to try and get his nephrons to activate, but he wasn't budging. We were talking about, at least transient renal replacement pretty quickly after this, but not without getting some more testing. Yes, and we'll get to that. Here's the second thought. Why didn't he have a hemoglobin response? Why didn't he have a hematologic response? This is, we don't know about pulmonary hypertension at this point, but we know that everybody gets their hemoglobin improved on this. So, he was getting iron repleted, but maybe it wasn't available. Maybe he was having a chronic inflammatory state. Maybe it was related to his failure to thrive. Maybe he's just bleeding, Maybe now that we understand a little bit more about some of the side effects, maybe there was occult bleeding associated with the drug. That didn't occur to us at the time. Okay, so a lot of possibilities. All right. So you wanted a right heart cath theta? Okay. These are the results. Okay. So pre-sotatercept, actually his pH is, moderate on triple therapy. I told you his PVR was around 5, and his output was reasonable. But then on sotatercept, what we noticed is that his output had really jumped. And I don't have his SVR here, but I can tell you it was a lot lower than when he went in. And his PVR had basically normalized from 5 to 1, and we put this together as high output failure due to excessive vasodilation on his triple therapy. And we weren't expecting this because we thought that we had a good echo lab that would tell us the truth, and we were thrown. So the right heart cath allowed us to take him to CCU to wean that Remodulin. We were worried about what would happen, but it came off very easily. They were going to cover him with inhaled. They didn't have to do that. And then within a day, his kidneys perked up and he diuresed. Within 3 days, he was out of there. He was off of the prostanoid at that point. He remains on 2 drugs. He's done well. And then we tracked him a couple months later, And with everything settling out, his hemoglobin finally jumped up to the degree that we would have expected to from the beginning of the study. So, but there's more. There's possibly more going on than that. But that's how we put them together. Is that we think that maybe perhaps with some vasodilators more than others, sotatercept may sensitize you to their effects. And for this gentleman, he seemed to be very responsive to the prostacyclin. There might be a scientific reason for that. That's something that some folks are looking at on the clinical and preclinical side. I don't know if there have been efforts to try and wean him further from his dual therapy. And we think it's probably his hyperhepcidinemic state, possibly related to the high output failure. But he probably had to lose it from somewhere, so more is probably going on there. And that's all I had.
So thanks for the interesting case. And, so based on this, and it's kind of interesting that, you're pointing towards all of these measures that are related to his anemia and failure to increase his hemoglobin hematocrit. What are the usual labs that you would want to get before you're starting a patient on this? What would you continue to follow, and how frequently would you follow it if you didn't see your desired effect?
So we kind of knew he was iron deficient, and he was on his perfunctory iron replacement. I don't know if we could have been more aggressive about giving him IV iron.
Yeah.
That might have been helpful, but without doing anything special, just by fixing his physiology a little bit, that seemed to improve. But so people think that the hemoglobin increasing effect probably contributes to maybe 10%. That's what Merck estimates is the contribution to the function from the hemoglobin raising effect. So it'd be nice to take advantage of that because it's not insubstantial.
Sure.
And so, I don't think there's anything fancy, but maybe think of IV iron sooner to make that available if that's the issue.
You following TSATs?
I'm not.
So, yeah, we were talking about this earlier today. This came up, so.
Anybody who you think is having what you would consider a response to sotatercept that you don't expect, almost like any other drug or any other situation like this, you need to know what their hemodynamics are so you can have some idea of what you're actually doing.
Absolutely.
And that as much as we try, or certain of us try not to recath people, in situations like this, there's nothing you can really do without the information that you really need.
Absolutely. Yeah. No, we were genuinely surprised.
You also mentioned that there's mechanisms by which sotatercept can sensitize patients to some of the effects of the other drugs. I mean, what are these?
So there's some older literature that suggests that BMP signaling can regulate the prostacyclin pathway and even the prostacyclin receptors. And so this is a thought that might happen. I don't know how many times we've actually done right heart caths at the same time that somebody's starting sotatercept. I've always wondered if there might be something you could see acutely with the infusion. And I think people are running studies now with cardiomems in this and related drugs, and so that's going to be pretty revealing on what are the kinetics of this hemodynamic response. We can see 6-minute walk distance improvements in 8 to 12 weeks, right? So you wonder if the hemodynamic improvements actually precede that.
The other obvious question, which I don't know if you want to get or we want to get into, is are they going to be similar, or do you see the same effects with Keros drug, which you can't talk about yet?
Because we don't know. Nobody knows what will happen, but these drugs are designed not to raise hemoglobin.
In theory, the Keros drug may not have the same effects on like hemoglobin and stuff like that sotatercept does. Is that going to I mean, it'll be interesting to see if that makes a difference.
I mean, that's the question. That's what we want to learn from that study. Yeah, that's great.
When will we learn that?
I think they closed that trial last month.
Phase 2 studies, full, it's done.
Yeah.
Right.
So the RCT will lock database probably April.
Good job, Dr. Farber.